представлення. Ми сьогодні зібралися великим колом тут в залі в Києві із 4 регіонів нашої України. Це з Полтавської, Дніпропетровської, Рівненської та Львівської областей. Для того, щоб поговорити про, як на мене, дуже важливу тему – це доступ до медичної допомоги та те, наскільки мобільна медична допомога в цих умовах, в умовах повномасштабної війни є затребуваною, потрібною. І поділитися досвідом проекту «Діємо для здоров'я». Це україно-швейцарський проект. І не просто так ми будемо про це говорити, тому що до того, як були запущені дані мобільні команди медичні, було проведено декілька досліджень для того, щоб зрозуміти, наскільки є ця потреба необхідною на сьогоднішній день. І якраз про це я би хотіла поговорити. Так, я буду представляти по ходу спікерів, бо в нас їх дуже багато, ми все одно можемо їх забути з самого початку, тому коли буду звертатися до людей, буду представляти. Але рада, що в нас тут в залі є керівниця Департаменту медичних послуг Міністерства охорони здоров'я України і представники проекту «Діємо для здоров'я». Давайте тоді розпочнемо. Пані Галино, я хотіла би до вас звернутися. Я знаю, що були проведені певні дослідження для того, щоб зрозуміти, наскільки мобільна медична допомога є зараз потрібною. Можете поділитися певними даними, на що ми орієнтувалися, коли запускали даний проект?
Доброго ранку всім. Дякую, що ви долучилися до цього заходу. Справа в тому, що наш проект не був розрахований на гуманітарний компонент, і він практично працював як проект розвитку. І, звичайно, ми мали реагувати на цей компонент, тому що ми працюємо з людьми, які є хворі на хронічні захворювання на цей час, а також люди, які потерпають від війни. Було проведене дослідження «Градус», і ми зрозуміли, що проблема віддалених районів, проблема малозабезпечених людей, вона не просто не вирішена, вона стала ще гіршою, ніж вона була. І питання доступності ліків, і ви згадаєте перші дні війни, коли практично люди скуповували все, що було в фармації, але без надії на подальші якісь поставки. І люди, які залежні абсолютно 100% від ліків, вони були в ризику залишитись без цих ліків. Нам було відомо, що десь 75% людей просто загубили оцей зв'язок з своїми первинкою, тому що рухнула логістика, тому що транспорт і багато інших речей. І величезна кількість людей стала потребувати психологічної допомоги. Я не кажу психіатрична допомога, ну хоча б психологічна допомога. І оце лягло в основу розробки стратегії. Ми це почали робити практично в кінці березня, на початку квітня в нас вже було готове дослідження, яке нам, власне, допомогло зробити дизайн цих команд. Мій колега зараз буде говорити про це. Дуже дякую.
Дякую. А можна я ще вам одне запитання задам? Просто, щоб ви, можливо, декілька слів сказали про проект «Діємо для здоров'я», тому що дали трошечки контекст. Ви сказали, що займається хронічними захворюваннями.
Перша фаза проекту «Діємо для здоров'я», яка підтримується урядом Швейцарії, виконується консорціумом організацій. Це GFA Consulting Group Гамбург, це українські організації Фонд здоров'я жінки, планування сім'ї, і це організація One Health, яка займається всіми комунікаціями, медіа, кампанії, імплементуємо проєкт. У нас 3 основних напрямки. І саме головне – це наші партнери, це науковці, які працюють в університетських клініках Женеви, це теж Швейцарія, які фактично дають нам технічний супровід. Ми працюємо і плануємо, і продовжуємо працювати по зниженню факторів ризику, які можуть спонукати розвиток хронічних захворювань. Зокрема, ми концентруємось на серцево-судинних і діабеті другого типу, який зв'язаний якраз з багатьма факторами ризику. Ми працюємо з шкільним здоров'ям і почали дуже інтенсивно в цьому плані працювати в зв'язку з тими державними урядовими ініціативами по реформі школи в сторону здорової. Ми працюємо з первинкою і, зокрема, з тим, що в нас залишається за бортом, це профілактична медицина, але ми працюємо із людьми хворими маркерами на ніс. Це люди, які вже мають хронічні захворювання, для того, щоб відпрацювати ці моделі якісної медичної допомоги, особливо з акцентом на периферію, на тих людей, які мають значно менший доступ до можливості медичної допомоги. І ми працюємо з національними компаніями, безпрецедентними по своєму розміру, яких ніколи в Україні ніхто не проводив. Я не згадую ніколи, щоб публічно рік ми говорили про діабет другого типу, про те, що треба вимірювати цукор, про те, що треба попередити всі розвиток ускладнень. В нас дуже потужні напрацювання. Ми теж працювали дуже цікаво з медіапокриттям при ковіді, а це питання якраз турботи про своїх близьких, це навіть не питання масок або цього. І такі наробки. Зараз плануємо дуже серйозну національну кампанію по сердечно-судинним захворюванням, тому проект у нас потужний, і він, я сподіваюся, буде все-таки проектом розвитку. Ми пройдемо цю гостру фазу і перейдемо до проекту розвитку. Дякую.
Дякую, Галина Павлівна. Це було важливо для того, щоб ми розуміли весь контекст, що неінфекційні захворювання, вони є в пріоритеті, і я сподіваюся, для держави також. Але зараз ми поділимося тими напрацюваннями, тим досвідом, який ми отримали з роботою наших мобільних медичних команд. Я запрошую переглянути коротке відео про те, який досвід ми отримали. Потім поговоримо з Владом, які ми винесли висновки з цієї роботи. Будь ласка.
Мене звати Vladyslav Zbanatskyi. Останні 7 місяців я координую роботу з первинною ланкою медичної допомоги в Україно-швейцарському проєкті «Діємо для здоров'я». А віднедавна наша команда запустила ще один дуже важливий напрям – це робота мобільних медичних команд. Зараз триває повномасштабна війна, яка впливає на суспільство завжди однаково. Вона забирає життя та здоров'я. Здоров'я вона забирає в усіх, найбільше в людей, які мають неінфекційні захворювання. Це серцево-судинні, цукровий діабет, онкологічні та інші хвороби. А якщо немає можливості діагностувати і лікувати їх, вони стають справжньою невидимою бідою. Тому перед нашою командою постало питання, як проєкт «Діємо для здоров'я» може допомогти безпосередньо людям і системі охорони здоров'я зокрема. Ми вивчили досвід інших країн під час збройних конфліктів, проаналізували локальні проблеми і вирішили запустити мобільні медичні команди у пілотних регіонах проєкту. Це Дніпропетровська, Полтавська, Львівська та Рівненська області. Їх мета – забезпечити послуги первинної медичної допомоги там, де доступ до них з різних причин є обмеженим. Зазвичай така команда складається з сімейного лікаря, медсестри, психолога, інколи медиків та волонтерів із місцевих громад. Що роблять команди на місцях? Це діагностика, електрокардіограма, тестування рівня глюкози, холестерину крові, вимірювання тиску. Лікарі консультують і призначають необхідне лікування. Крім того, видаються ліки на досить тривалий період. Відбувається перенаправлення за потребою до вузькопрофільних спеціалістів. Основний ще фокус є надання психологічної допомоги. В наших командах працюють дуже кваліфіковані психологи.
Слава Ісусу Христу!
Слава Ісусу! Присідайте, будь ласка.
Сідаю.
Цукровий діабет першого типу, інсулінозалежний,
Ні, я тільки ще на таблетках.
на таблетках, це і другого типу.
Дивіться, то є по 500 мг,
Ну, то
але
я
ви
маю.
будете по
Бо то
2
я-
таблеточки
То я
пити.
маю такий.
Але вам ще треба буде і в обід пити. Я вам зараз це розпишу. Добре?
Добре, добре.
Вибирайте.
П'ю від холестерину
Вазеліп.
вазоліт.
Ви його виписуєте по безкоштовних? Ні.
Дочка,
Я вам випишу.
Дочка купляє.
Але мені треба, щоб ви мені задзвонили, щоб я бачила
Добре.
вас.
Добре, я вам перезвоню.
цій місцевості немає амбулаторії, немає фельдшерсько-акушерського пункту. Тут проживає 204 людини. І, власне, люди хотіли, щоб була для них більш доступніша медицина, власне, в їхньому селі. Тому ми приїхали в це село для того, щоб люди відчули, що про них не забули.
Холестерин 5,7 у вас. Зараз, одну хвилиночку, я вам
Ви мені
віддаю.
поясніть по-хлопськи, то добрий чи не
До
здали?
7 в межах норми.
Ага, дякую.
Наші команди комплексно вирішують питання, пов'язані з неінфекційними захворюваннями. І цього б не сталося без співпраці з регіональними департаментами охорони здоров'я, які визначають потреби конкретної громади і скеровують мобільні команди саме туди, де необхідна допомога. Медичні препарати, які ми видаємо людям на тривалий період лікування, дозволяють вчасно розпочати, не переривати або відновити терапію і в подальшому отримувати медикаменти за програмою «Доступні ліки».
Моя робота полягала в тому, щоб робити людям кардіограму, вимірювати цукор в крові, холестерин. І були такі випадки, що ця робота була дуже необхідна. Чому? Тому що ми попадали в села, куди не їздили маршрутки не тільки під час війни, а ще з початку карантину. І люди не могли після інфарктів, інсультів перевірити стан роботи свого серця, не могли навіть зняти кардіограму, проконсультуватися з лікарем. Були такі, кого цукор вимірювали в перший раз, були високі показники на фоні стресу, багато в кого родичі на війні, багато переселених, в яких також був стрес.
Протягом червня-вересня цього року вже більше 7 тисяч місцевих мешканців та внутрішньо переміщених осіб отримали медичну допомогу та потрібні ліки від наших мобільних медичних команд. І на цьому ми не плануємо зупинятися. Адже ми бачимо, що люди почали звертатися за медичною допомогою частіше.
І тиск перевіряли, і цукор перевіряли, все перевіряли. Я задоволена. Всі лікарі мене перевірили.
Да, ось дивіться, цілу кучу лікарств виписали і від давлення виписали, і це від давлення, ноги в мене пухнуть, виписали.
Щоб збирати дані та звітувати, ми розробили застосунок, який працює навіть без доступу до інтернету і дає можливість командам уникнути паперової роботи, а нам дозволяє бачити інформацію про роботу команд у режимі реального часу. Досвід роботи мобільних медичних команд «Діємо для здоров'я» може стати у пригоді і іншим організаціям, які вже планують або працюють у подібному форматі. Загалом, нічого ж такого складного. Головне – діяти. Діяти для здоров'я. Бережіть себе.
Так, я думаю, що всім вже
I think everybody understands how the mobile medical teams work, but I would prefer if you share any lessons learned from this work because it's important for the state as well to learn how it works. Well, it's hard to add anything after the video. Let's review the presentation so that we can see the results received. As for yesterday, so we have provided approximately 8,000 services to our people in the regions, and you can see the scope in particular of internally displaced persons. And we worked in the field. So for the low mobile groups of the population that indeed required the biggest assistance, we provided services in the field. And in general, it's about 6,200 services because it's about services and people because we have provided both medical and psychological assistance. So it's in particular people who have come to receive the services. And I think it's a really good element for our work that would be applicable for the other teams as well. And when we were planning the work of our mobile teams, we had certain reservations, whether it would be applicable, whether the people would be ready to go to a psychologist. And we have worked on this aspect with our psychologists and the mobile teams and the family doctor, so that the people would know the criteria, and the medical workers would also know the criteria, and they would know the systems when the people need assistance, and that's why we involved medical workers for referral inside the team. And the findings of our team. I should say that our core clients are women, 2/3 of the applicants. The approximate age of the applicants is about 50 or over 50. And you can see the breakdown of diseases of our clients. So this is hypertension, cardiovascular diseases, diabetes second type, other non-infectional diseases, lung diseases, etc. And on this slide you can see the trends in the use of medications provided by our teams. We have procured the basic package recommended by the WHO, and basically we can see that we have something to propose in terms of improving this package, because we have understood how the focus should shift in terms of anti-hypertension, anti-diabetes medications, probably including new groups of medications to this list. And the main focus is not to lose the experience we have received.
Люди в віддалених районах, вони дійсно не мають.
We can see that our people in distant regions, they do not have the opportunity to receive medical assistance, and war has aggravated the logistics. The primary segment lacks personnel because they fled abroad or were mobilized to the armed services of Ukraine. And in communication with the locals, we became aware that the deficit was also in place before the war. So we need to create the conditions for the medical workers to be interested to come to the rural area to work there, and probably we can also organize guest visits and so on. But we have received significant experience that we can share with the other teams. We have simplified the work of our mobile teams in terms of entering mobile data, and I sincerely hope that this experience is gonna come in handy, because we can see that some organizations are planning their work in the Kharkiv region, so we would like to make their life easier. Okay, thank you. That's valuable. We can discuss it in detail, and we have lots of speakers in the regions, and Natalya and Oleksandra Mashkevych from the Ministry of the from the Ministry of Healthcare of Ukraine. And I would like to ask Natalya about the access of the population to primary healthcare. What are the plans of the state? Hello, everybody. Thank you so much for this very timely question. And the Ministry of Healthcare, due to the project like this one, can monitor the situation, and we can state that we have problems with primary healthcare. But the state has provided all the mechanisms that, due to their availability, can make medical healthcare at the primary level accessible in all the regions. In 2017, the Family Doctor Program was launched, and every citizen can conclude a contract with the family doctor, and the state increases the per capita rate annually, and this is the amount paid either to the healthcare institution or a private entrepreneur being a doctor.
Представленим на
And what Vladyslav has said, we have seen it from the video and on the slides. This is a part of the package guaranteed for a citizen having concluded declaration. However, in some regions, there are problems with the organization of this assistance. Indeed, doctors having graduated from the medical institutions, education institutions, they are not interested in going to the rural areas. They are not satisfied with the money, and this is in spite of the fact that there has been a dynamic increase in salaries since 2017. However, the discrepancy between the first segment and the second segment was rather striking. So the primary link earned much more, and we tried to make up for it, and we guaranteed decent salaries for all the doctors. But it's a very critical situation when we have absence of non-infectional diseases diagnostics like cardiovascular diseases, diabetes, etc. And unfortunately, we have been observing both during the war period and before that, we observed patients who applied to the medical institutions with complications already of the hypertension disease, like strokes, neuropathies, and unfortunately this problem indeed exists. And at present, we're working not just with the project, but also with the WHO. We have been developing indicators of the quality of provision of medical assistance at the primary segments, and modernization of accesses to primary healthcare is based on the fact that almost all the population requires psychological assistance, and we work on this component, and we try to create multidisciplinary teams at the level of the community comprised of the primary level medical workers and psychologists, social workers, and such a form of assistance as a mobile team or telemedical consultation is indeed essential both for the distant regions and for the territories deoccupied. And we are aware that people of those regions have been left literally without access to medications, and crisis response, anti-crisis mechanism for medical services is indeed really important. Therefore, we support those initiatives, and we believe that this is crisis response and assistance at the primary level
на певними спеціалістами.
should be strengthened by certain specialists. Thank you. But the question remains, because you said that the state has done much, but the ministry and we all are working on receiving this assistance. Are you monitoring what is happening in this country? So are you planning, like the National Health Service, to introduce quality indicators, new packages of medical assistance? So what are your actions? Because people live, people die, people receive complications. How fast should it be? And how such projects can be part of this assistance for the state in this complicated period? Such projects are a big help for the state because 2023 is near, and we need to admit that the expenses for healthcare will be reduced by 13 to 15 billion hryvnias, and we cannot fund anything beyond that, so we are counting on the support from the international organizations and projects, because we should be aware that the budget is war budget at this stage, and it's focused on the defense sector, though we were trying to preserve some budget for the healthcare purposes, so it was reduced insignificantly if we compare it to other, let's say, segments. We retained most of it. Another question is the payment to mobile units. So there are other projects including doctors of primary medical assistance, and they unfortunately leave the occupied territories and are involved in those mobile teams. They have been paid for the declarations they concluded. They continue receiving payment from the state and continue working in spite of the fact that they are registered in the occupied territories. And those doctors are able also to enter information on any patient into the electronic system of the healthcare ministry. And we need to cooperate with the project so that doctors are able to enter the data into the centralized database, all the manipulations that were conducted. This will enable us to analyze the data. This would be much more efficient than having data on a certain quantity of people. And then there is my question to this project. I understand that the quantity of patients examined is clear, but I'm wondering what is their status? Have they concluded declarations or not? We need to analyze it with the local authorities, because doctors haven't concluded a declaration with the patient are obliged to provide medical assistance, and organizing their visits to villages is the question to local communities, because the state provides for funding of family doctors. Now there is an acute problem at the occupied territories in Kharkiv, Zaporizhia, and other regions. People leave, doctors leave, people stay without medical assistance, and we are forming mobile teams with our emergency center to provide medical assistance in crisis situations where there is no medical infrastructure, medications, or doctors, and we are going there in the regions where there is no warfare at the moment. The local authorities should be more serious about organization of medical assistance, and we as the state will help. Luckily, we have regional authorities present here, so we are ready to discuss it. Let's talk to the regions then. If I may, I would like to give the floor to Kvitnitska Tetiana, Deputy Director of the Healthcare Department in Dnipropetrovsk region. You are aware that Dnipropetrovsk region has a complicated situation now. Can you please put Tetiana on the screen? Hello. I wanted to ask you the question about the situation in Dnipropetrovsk region. Oleksandra said that regions are obliged to coordinate family doctors. Do you think this is realistic, and do you think that DMO для здоровья, or acting for health, is needed in your region in terms of access to primary medical services? Thank you. Appreciate the opportunity to express the position of the Department of Healthcare in Dnipropetrovsk region. I wanted to say that mobile teams are not an evidence that the regions are not working properly. We are cooperating with the mobile teams, and we are aware, as Oleksandra said, of their activities. We have a network of medical services in Dnipropetrovsk region, 66 centers for provision of primary assistance, and in spite of massive shelling, it's practically the contact line. The two healthcare institutions being shelled daily continue working, and we all continue working. And the system for the provision of primary assistance is working. We cannot say that any doctors have left abroad. Let's be honest and sincere. Of course, during the war, there is always a situation when people have to go out to provide medical assistance. And this reduces the workload on the existing system. And I would like to say we have provided services to 1,200 persons. And the medical workers are grateful for that, and people are grateful for that. And this is not an evidence that we are working bad. It's just to reduce the workload, which has increased due to internally displaced persons. It's not due to any gaps in healthcare. It's due to the increased workloads. And mobile teams and family doctors, express diagnostics, psychological assistance are facilitated by 6 projects. In spite of daily shelling, we are aware of this situation and we have feedback. We know how many people have been provided with assistance or hospitalized, and sometimes they have trouble getting to the pharmacy, and this feedback is one of the important components, and we're really grateful to the project for being aware what our needs are, because as it has been mentioned today, this is really essential. All the diagnostics, examinations will need to be entered into the system. And this is, homework, night work for the doctors. And the projects give us some physical satisfaction to be able to see the outputs of our work. And I can see a lot of familiar faces here. We have met personally and in Zoom, and we communicate daily. And the Center for Public Health is the coordinator of this project, really managing it very well. People are satisfied. Medical workers are satisfied. The healthcare department has provided feedback, and we will launch a mobile pharmacy, and that is an evidence that we know what to do, and we are very grateful therefore for the opportunity to cooperate with them and to provide together accessible and high quality primary medical assistance. Because the system is working and we support everything that needs to be supported in this complicated period. So thank you. We were aware that the system was working. Thank you for doing that. And what was mentioned in the video, that coordination with the regional departments of healthcare is essential, so that we know where the mobile teams need to go, where real assistance is needed, and deloading the system is really essential. But the war continues, and we do not know when the situation improves, because we're aware that this is one of the projects, and there are 6 more. We need to make this response more systemic and ensure that the people in need receive this assistance. We're not criticizing anybody. You are all doing fantastic job. And let's talk to Lviv. Lviv has accepted a lot of IDPs from other territories where there is active warfare. I wanted to ask you, this is a question to Mr. Chimaris, Director of Healthcare Department of the Lviv administration, or anybody from Lviv state administration. Can you let us know who is online? Oras Chimaris was called to the administration. He will not join us. But there is his deputy. I don't know if she is ready to discuss. But we have Mariana Sluzhinska, regional coordinator of our project. Mariana, maybe we will ask you. We are very flexible. Can you tell us how the mobile teams worked in the Lviv region, and probably any conclusions you made from the work of the mobile teams, and what is to be taken into account for the future? The work of our mobile teams was focused on distant territorial communities because we were aware that they need this assistance the most. And clients included both the residents and IDPs. So we started, as all the other mobile teams, in June, and there was a really big quantity of IDPs, and we expect new people to come, and people were disoriented, and there was a very high demand for psychological assistance, because the medics who are working with the population, we know that the psychotherapist and psychiatric worker are different categories, but we're aware that psychological assistance is essential in the time of warfare, and people in small boroughs and villages easily access psychological assistance. Another important moment in the work of mobile teams was the provision of medications, because especially IDPs did not have access to their medical documents. They couldn't buy medications. As a rule, elderly people did not remember what medications they were supposed to take, and it was a big plus. And I wanted to stress that mobile medical team provided their patients with basic diagnostic services like cardiography, and the most important service was diagnostics of sugar and cholesterol in blood. These were in high demand, and family doctors were supporting us in that. Thank you. You have confirmed what we have just discussed with Vladyslav. Can you tell us if Rivne is online and Poltava is online as well? Can you hear us? Yes, Deputy Director of the Healthcare Department, Halyna Maistruk. Glad to see you. Can you tell us about the situation in terms of access to primary health care and whether it's a real problem, and whether the mobile team was important in terms of assistance, and what does the department do to ensure this assistance. As Oleksandra has said, the mechanisms for medical assistance are functioning, and we unfortunately faced some challenges nobody expected. In particular, the fact that and Oleksandra has mentioned that some doctors are not willing to go to distant regions, and Rivne region is characterized by bigger village population, and the northern regions have a higher density of rural population. We have some villages that are 200 kilometers far from any civilization. This was always a problem in the region, but especially at the time of war. Secondly, the center of primary healthcare assistance has provided their vehicles to the army, and if there is assistance in terms of delivery of medical personnel or automobiles, it's helpful. And it's not only about the challenges of war. We have villages where medical institutions have been closed completely. There was some temporary units for provision of medical assistance, but there is only junior personnel at best, and the doctors are not there. This is regarding medical assistance, and we are going to assign family doctors to those villages. So everything that is going on at the state level is, let's say, reflected at the regional level. Also, we have a large quantity of IDPs, and only 5,000 to 7,000 of them are in cities. The others are in villages, whether they have a signed declaration or not. And we are working sort of in a, let's say, rapid reaction regime. And it's important because these are often low mobile groups, or there is no transport, regular transport in the villages, and it's not because it aggravated because of the war, but it was absent all of the time. So I will not get into this now. Provision medical services to low mobile groups in distant villages is important, and we cannot run away from it. And we had a feeling that this, let's say, service is needed. And the provision of, let's say, medical services at the primary level is no less important. Regarding the work of the mobile team, there was a presentation. In the video, we indeed are working on that, and mobile teams are aware of it. And I thought personally that it would be, let's say, less smooth, but people are really organized, and in case there is some diagnostics going to them. So this question remains open. And intensive care cannot transport people for regular procedures, and people cannot get there themselves. I mean, the population requiring medical assistance. If this information is enough, or I can answer your questions. Thank you for sharing. It's good that you understand the problems that people in the regions tackle, and I hope you will continue that, and the project will be extended. And I think that when there is such a crisis in the country, we can either escape or use this crisis to test new approaches that we can use at the level of the state. And these mobile teams are nothing new, and in the other countries where there were conflicts, the system maybe failed, but here the system is working. But here we didn't know if the mobile teams were needed. But the question is not just about war. It's a problem that existed a long time ago, but it became more relevant. And it's cool that you have you have the opportunity to learn this experience. Just wanted to add, indeed, in many countries, not having primary healthcare network or extended network, they use those mobile teams, going directly to the place of residence of the people. And here this experience will be used until we reconstruct the infrastructure. We should all understand when we come to the deoccupied territory, we can see that the medical infrastructure is devastated, and some institutions were either ruined or robbed, including computers, conditioners, and endoscopes. So we should be aware that this instrument can help us to react to the crisis and work on the territories that have been cleared from occupants.
Держава буде дуже вдячна і проектам, які підтримують саме надання.
And of course, the state is grateful to the project supporting us and the regions who, on their level, can create such mobile teams, accessing IDPs and people in distant areas. So, of course, this is going to be a stable practice for a long time. Yes, it's a question about people as well. So infrastructure is important. Yes, there were cases when there were no premises and we brought a vehicle to conduct medical examinations because the village was leveled with the ground. And about the psychologists, we are aware that at the level of the state and the project's psychological health, so this is being worked on, and it works because it's can be stigmatized, but a family doctor can refer a patient to the psychologist, and people are more open and positive about it. And this is an interesting, let's say, conclusion. At the level of the ministry and the National Health Service and the First Lady who initiated this, we are working on initiating interventions on first step medical assistance. We provide trainings from our partners, and we try to implement this assistance in the primary healthcare. And what I said about the multidisciplinary teams, they should comprise psychologists. We shall try to find the money, maybe in the per capita rate. For family doctors, I think that the project is doing very much, and I think that they're aware of that. We're now going to discuss it with the doctors. It's always important to have feedback from the field. I would like to invite to the floor Maria Gvozdyk from Poltava and Oksana from Rivne. We are from Poltava. And Rivne is with us. Thank you for that. Can you show your video? It's Oksana from Rivne. We have seen you on the video. We're glad to communicate. Can you tell us what the basic, let's say, impression was from going to the rural area? Because you have been working for the long time now. Of course, the main striking factor is absence of medical assistance in rural areas and villages. So there are villages where there is no transportation, and shuttle buses go on demand, and people physically cannot reach their doctors. And pharmacies where people can use accessible medications resides, but so they don't have access to such drugstores. So these people are either lonely or low mobile, and they cannot access those pharmacies. So people accept doses which are not adequate, or conflicting medications, or they treat like heart failure for example, breast problems. So because they don't have access to doctors. In this context, maybe you know if these people had a signed declaration with family doctors. Well, some. There were people who were elderly, and all the young people are at war, and these elderly women did not have anybody to bring them to a drugstore or a doctor. They were so glad to see us because they lacked really those medications. Thank you very much for this, for understanding how necessary this work is for providing these people with medications and treatment. Thank you, Oksana. And we have, as far as I understand, Maria from Poltava. Hello again. I've been talking about Rivne. What about you? What was the striking point for you? I can totally support what my colleague has just said about lack of access to drugstore and also absence of information for the patients about access to accessible medications. I have communicated with the medical workers. They said because there are no drugstores where they can buy it, so we are not telling people that they have such an opportunity. There was another negative aspect. Lack of information of patients that the family doctor can treat a lot of pathologies. They are used to rather primitive scope of family doctors, and when we bring the cardiographic device, we have to explain that the family doctor can interpret a cardiogram and assign treatment, and people were furious. And even in the case that there is a grave case, we involve a cardiologist, and then people started queuing, and then there is a psychologist, and then there was a queue to the psychologist. So it's the negative part which impressed me. So when you work in a city, you have signatories of your patients, so you conduct prevention, and when you get to the grassroots, each patient is a new one. You get acquainted with the patient, and then you teach the patient to eat, to take medications, because there was some absurd prescriptions, like people were given diuretics for the evening, and they didn't sleep. So there were some pros and cons, let's say. And when people are satisfied with receiving high quality medical assistance, they are, let's say, happy. Of course, there was some, notes or homework, and this would be, a good memory for them for the future. Thank you for this positive aspect. Thank you for your work and for raising the awareness among the patients. Thank you so much. And thank you everybody for the opportunity to talk about this. Thank you for doing this. Thank you, dear Ministry. Thank you for non-stop work. Thank you for building the medicine for the needs of the people. And I hope to see you soon. Let's continue sharing our experience. Take care and goodbye.